Hi everyone, welcome. My name is Sam Lockhart. I am a Senior Scientific Director with Perceptive, a neuroscientist and neuroimager, and an attendee here at the ADPD 2026 conference, where I'm very excited to talk to some of our speakers and panelists today as part of our 2026 Evidence to Asian Practice Roundtable session, where I hope we'll get to translate global insights into Asian clinical practice and bring world-class science closer to Asian patients and clinical practitioners. What we'll then do is launch next into our first session today, where we'll be talking again about real-world evidence to assess new therapies' effectiveness, safety, and cost. And I'd like to invite Dr. Kujuro to present on some of her material that she'll be talking about at the conference.
Since the introduction of anti-amyloid therapies, we have experienced a marked increase in demand, specifically for these treatments. And the waiting time for a first visit or center has extended to around 5 months. We started lecanemab in 2024 and donanemab in 2025. And to date, we have treated about 90 patients with lecanemab and 70 with donanemab. This session focuses on effectiveness, safety, and cost. I will briefly address these three aspects from our real-world experience. To assess effectiveness, we compared lecanemab-treated patients with historical controls matched for age and baseline MMSE diagnosed with Alzheimer's disease using standard clinical criteria from the period before amyloid confirmation became routine. Therefore, amyloid status in the control group was unknown. At the group level, MMSE did not show a clear difference at 6 or 12 months. However, individual trajectories diverged over time, suggesting heterogeneous treatment response. In ADAS-Cog subdomain analysis, particularly word recall, we observed a consistent improvement trend, suggesting that some cognitive domains may be more sensitive to treatment effects in real-world practice. Regarding safety, all ARIA events were asymptomatic, and in both lecanemab and donanemab. ARIA-E and ARIA-H occurred infrequently, on the order of a few %, which is lower than reported in pivotal trials. Infusion-related reactions occurred in approximately 1% of lecanemab and around 10% with donanemab. The clinical patterns differed. Reactions with lecanemab typically occurred from the evening of the infusion to the following day, whereas donanemab reactions were immediate type reactions during infusion. Because some patients discontinued treatment due to infusion reactions, particularly with donanemab, we introduced premedication for the first 4 infusions, which improved tolerability in routine practice. The most challenging issue for us in real-world practice is cost and sustainability. Although patients can be referred to community clinics after 6 months, in reality, very few clinics take over treatment. This is not primarily a medical issue, but rather an operational and economic challenge under current reimbursement. And as a result, treatment remains concentrated in dementia centers like ours. For lecanemab, a major unanswered question is how long treatment should be continued. In our cohort, more than 90% of patients continue beyond 18 months. Because this therapy is an anti-amyloid antibody, the therapeutic goal is amyloid removal. This raises an important cost-effectiveness question. Once amyloid has been sufficiently cleared, should treatment be continued indefinitely, or can it be stopped or de-escalated? In contrast, donanemab offers a time-limited perspective. In Japan, amyloid PET can be repeated at 12 months. An Asian trial data suggests that around 70% of patients achieved amyloid clearance by that time, allowing treatment completion in many cases. From the cost and sustainability standpoint, this approach may be easier to justify for selected patients. Ultimately, real-world data clearly indicate that not all patients benefit equally. To improve cost effectiveness, we need to better identify patients who are most likely to respond and to avoid treating patients who derive little benefit. In conclusion, anti-amyloid therapies show acceptable real-world effectiveness and safety, but they raise critical questions about cost effectiveness and sustainability in a national health insurance system. Real-world evidence will be essential to determine who should be treated and for how long. Thank you very much.
Thanks for your presentation. May I ask that the number, do you think is satisfied or much less than expected?
We treat lots of patients, lecanemab maybe 70 and lecanemab 90. So we have to treat so many patients. Not many doctors are in our hospital, so you have to manage.
As you mentioned, you are a regional hospital.
In
this area.
According
to epidemiological data and the eligible patient, the population should be X, and eventually you treat 160 patients. So the X and this number is a much meet your prediction or much less than the expectation.
No, I think in Japan, our hospital treat maybe one of the most treated most
high volume center.
Yes, I mean, if 100 patients are eligible for the treating criteria, but eventually only 20 got treated. Do you know? Can you explain why the big differences existed?
What do you mean?
Perhaps if you've already treated, then say about 160 participants, how many more participants out there that were maybe considered for going on treatment but didn't go on it, or haven't even been evaluated?
They are waiting for long. So
waiting
time is 5 months. So I don't know. Maybe eligible patients are waiting.
How is that going? Is that much slower than you would have expected or hoped for sure?
We didn't think so much patients come to our hospital.
There's a very high demand.
We didn't think.
with slower throughput and not enough supply to get around to all of these individuals who are hoping for this type of therapy.
Because you know the DMT actually is covered by Japanese government, although the patient must pay for some money.
So 10% of
but not every patient wants to be treated, right?
But most of the patients come to our hospital for this treatment.
Okay, it's very important for us. Thank you.
Can I ask one question? Does the government cover the insurance even after the 18 months of treatment?
If they're effective, they will be paid by the government.
My title of is the feasibility, safety, and efficacy with lecanemab in China. Is a multi-center real-world study in China, and we all know that lecanemab is a newly approved antibody targeting amyloid plaques for treatment of early onset Alzheimer disease. And it was approved by China government 1 year ago. And this study aimed to evaluate the safety and short-term biomarkers and cognitive changes of lecanemab in Chinese clinical practice. This is a multi-center real-world study involved patients receiving lecanemab treatment across 7 hospitals in China. And patients underwent comprehensive assessment before treatment. Lecanemab was administered via intravenous infusion every 2 weeks, and the treatment-related symptoms were monitored through self-report, and amyloid-related imaging and abnormalities were assessed via MRI, and amyloid and tau biomarker changes were measured using PET imaging or PET biomarker testing. Follow-up cognitive assessment were evaluated after 6 months of treatment, and the short-term outcomes were analyzed using linear fixed effect model without an treated control group. A total of 407 patients were included in the study, who received at least one lecanemab infusion, and with a mean follow-up time of 6 months. This mean age was the mean age of the patients were 68 years old, with 67% of patients being female. Of the participants, 15.7% were APOE4 carriers, and 18.3% were at a biological stage C, with top hat confirmed diagnosis. During the study period, 22% of the patients experienced treatment-related symptoms, and 12% developed at least one amyloid-related imaging abnormality. Only 4 symptomatic and 7 severe amyloid-related imaging abnormality cases were reported. APOE4 status were not related to adverse events in the Chinese real-world study, and patients with a high number of macro hemorrhages at baseline were more likely to develop adverse events. No significant difference in adverse events were observed between the moderate Alzheimer's disease dementia group and the mild cognitive impairment group. By the end of the research period, about 9% of the patients withdraw from lecanemab after 6 months of treatment. Favorable short-term outcomes in biomarkers, including p-tau217, JPP, were observed, and the stable cognition function was also observed. This study demonstrates that lecanemab treatment is feasible and well tolerated in Chinese population, with lower risk of adverse events and favorable short-term outcome observed. Administration of lecanemab in moderate AD dementia population was relatively safe, and further studies are warranted. I want to in summary that from our study we found that the most important is that is for lecanemab is very safe in Chinese populations, and only about 10% with every HRVE side effects, and only 1% with severe symptomatic side effects. And we also found that APOE4 status was not associated with RH side effects. And we also found that we all know that lecanemab was approved for early stage Alzheimer's disease, including MCI and mild dementia. However, we found that it's also safety for moderate AD dementia patients from our population.
Dr. Yu, thank you for your presentation. About your 407 patients, did you mention the infusion-related reaction? Is the percentage high or low?
You mean for the
infusion-related
IRR?
IRR.
injection site reaction.
During the injection,
systemic.
patient may have symptoms.
It's very high.
Very high?
I mean, for the infusion
Related.
it's high, about more than 13%.
So did you use a pretreatment such as acetaminophen or antihistamine to prevent?
We don't give this kind of prescription. However, for currently for lecanemab, we give them this.
Actually, in my hospital, we use pretreatment for both lecanemab or donanemab. So the IR is very, very low. Maybe you can use this treatment.
Thank you.
So you treat many of the patients are biologically stage C. So that means the tau is already accumulated in the brain, right?
Yeah.
So it's advanced, fairly advanced stage. So are they effective? Is lecanemab effective for those patients? I wonder.
You mean for the
Effective.
effective?
I know it's safe for. You told me that. It's safe
We
for-
found that the brain amyloid burden significantly reduced with the lecanemab treatment in the short-term follow-up, and we also found that the plasma p-tau217 (GFAP) also significantly reduces with amyloid antibody treatment. And of course, as we didn't include the ultimate disease without amyloid antibody treatment as controls. Hence, we only found that compared to the baseline, their cognitive function was stable.
Stable
Yeah.
for
So
those patients.
Yeah.
So you're able to treat people with perhaps more advanced tau or more moderate stages of dementia and still see success and still see not as many safety considerations as we're seeing in the trials.
Perhaps the main important finding from our study that is really very, as I know, it's the last real-world cohort study, and we found that it's really very safe in China. And overall, we found that very interesting ApoE4 status was not associated with every study factor.
So your patients are fairly young compared to maybe our hospital. So that's because maybe ApoE epsilon 4 they're carriers over.
However, the frequency of ApoE4 positive was high.
So you recruit those young patients intentionally.
No, it's a real, it's a real world study. Perhaps in my memory clinics, I will if the patient age is more than 85 years old, perhaps I didn't recommend them to because that is.
At this meeting, I have made a presentation updating our ongoing observational cohort study focusing on the preclinical Alzheimer's disease, and that is named J-Track cohort. And I also made a brief introduction of our national registry that for the patients treated with anti-amyloid drugs. And for the first part, we have started the J-Track trial ready cohort back in 2020. Yeah, so that has a 5 or 6 year tradition, and we have already screened 865 individuals by cognitive testing and some sort of amyloid PET, prometabile or flutamidamol, and we are now started to quantitate the plasma biomarker first, p-tau217, and then this time we have added covered by some of the participants by the MK60-40 tau PET, and also by the EMTBO-243 biomarker in cooperation with the C2 and company. So what we have found is that, as has been evidenced many times, p-tau217 is a very strong predictor of amyloid positivity by evidenced by the PET imaging, and the AUC by the right drawing the rock carbon, it is close to the 0.9 or in the preclinical AD population as well. Yeah, and then we have had almost half of the amyloid verified cohort members by MK PET scan, and Dr. Kenji Ishii, our Tokyo Metropolitan, is an expert in amyloid and tau PET analysis, and he has subdivided PET images in relation to the imaging-based Braak staging. So what we have found is that roughly amyloid burden, amyloid level is roughly correlated with imaging-based Braak stage. But although the imaging-based Braak staging, and so the represents the pattern of distribution, not the intensity. So overall, the tau burden and that can be then quantified by the centau level based on the SVR. That is relatively low. And we were wondering if the EMTBR-243 in plasma may serve as a predictor for the progression from preclinical to the MCI stage, those that are very early progression. But what we found is that almost all the samples out of the 110 mass spec quantified samples showed below the detection level. So, and then we had so much discussion with the C2N scientists, and then we confident that quantitation was done quite properly. So our current assumption is that EMTBR may be biomarkers that may represent that tau burden in a bit advanced stage, including the late MCI or mild to moderate Alzheimer's disease, where tau burden shown by the tau PET is so robust. So lastly, we had made a snapshot on our ongoing patient treatment, amyloid antibody treatment registry. And so far, by the data presented by the ASI and Eli Lilly, almost 20,000 early symptomatic Alzheimer's disease patients have been prescribed with either of the drug. And our registry covered only part of those, but so far 1,200 patients have been registered to our registry, and we had made ApoE genotyping, and the ApoE epsilon-4 prevalence, that is 1 epsilon-4 and 2 epsilon-4, that is 59% in the cohort. And the prevalence of the homozygous was 8.7%. So that was very lower than we had expected. And currently we are starting to correlate area incidence with the ApoE, but it's just ongoing. And lastly, we error quantifying the p-tau217 levels that are in the pre-treatment samples and then post-treatment samples in the real world. And then we are now seeing that it's very natural that post-treatment samples show a statistically significant reduction in p-tau217 level. So that is ongoing by a collaboration with Fujifilm Bio Company. So we hope that p-tau217 may serve as a partial efficacy monitoring marker in the real world clinical practice. So that's all for now. Yeah.
I hear that the ratio p-tau217 over A-beta
40.
Yeah, it's approved by the FDA. So is it better to combine those markers?
Yeah, that's a very very good point and interesting discussion. And probably they have initially submitted that ratio to minimize the indeterminate population by using two cutoffs. So within they have found that if they divide 217 by 42, they can reduce the intermediate zone less than 10%. The intermediate people may require additional amyloid PET. But at the last CTAD meeting, there was some criticism from the Mayo Clinic presentation that it may overestimate the amyloid positivity. So there's still this discussion about that.
Actually, maybe I could ask one final question out of my own interest. We're talking about the integration of imaging and fluid biomarkers, and these fluid tools are becoming much more prevalent, showing a lot of very valuable data. But there's a lot of concerns about things like different demographic differences that may contribute to them, or comorbidities, or concomitant treatments. I wonder if any of you would like to share any of your thoughts on that.
Very good point, but it's a burning future question. So, currently we are seeing that correlation between different parameters, but as you mentioned, we may have to integrate them to make some unified measures to predict the brain state and also the response to the therapies. And then we have to consider the comorbidities. That is very vital.
I'm Kee Hyung Park at the Korea Joyart Registry. And before I start, I'd like to the Joyart first. And the Joyart stands for the Korean Joint Registry for Alzheimer's Treatment and Diagnostics. So today I will talk about the result of the Joyart the registry. And the Joyart is the nationwide real-world registry led by Korean Dementia Association to collect data on newly approved Alzheimer's treatment and diagnostics. Currently, 45 academic centers and general hospitals are participating in this registry in Korea. And lecanemab was the only DMT in Korea, and lecanemab was approved in May 2024 and started to prescribe December 2024. And as of February 2026, a total of 901 patients had been enrolled, and now we are data cleaning for 770 enrolled patients by December 31st, 2025. Among them, 652 patients received lecanemab treatment, and the longest one is 29th infusion. And these lecanemab treated patients, the mean age was 71.2-year-old, and 62.8% were female. And the mean body weight and the MMSE, average MMSE score were a little lower than the Clarity AD. The mean body weight was 62.4 kilogram, and the average MMSE score was 22.5. And the ApoE proportion was 61.5%, which was also slightly lower than the Clarity AD, 68.9%. And in terms of diagnostic distribution, the 90% of patients were diagnosed as MCI due to AD and mild AD dementia. However, 10% of patients, there were also moderate to severe AD, SCD, VD, and even DLB with amyloid pathology. And regarding the comorbidity and co-medication, 12% were taking antiplatelet agents, and even 2.1% were receiving anticoagulation therapy. And the baseline MRI finding was that 31% had microbreeds, and among them, 2.9% of patients had more than 5 microbreeds, and 1.7% had superficial siderosis, and 7.3% of patients had Fajarka scale 3 in their MRI. And therefore, we could know that in real-world practice, lecanemab is sometimes prescribed to the patients with higher risk of ARIA, despite general recommendation. And now I will talk about the safety outcomes, and the instance of infusion-related reaction was 25.8%, which was comparable to the Clarity AD trial, 26.4%. And most reactions were mild to moderate, and fever was the most common symptom, and then followed by headache, rash, nausea, and vomiting. And the IRR occurred most commonly at the first infusion. The next one is ARIA. The overall ARIA instance was 9.5%, which was quite less than, approximately lower than, half than the Clarity AD clinical trial, and especially ARIA-E was 2.8%, ARIA-H was 7.7%. And the symptomatic ARIA only occurred 0.6%, which was also lower than the Clarity AD, 2.8% here. The interesting finding was that when we stratified ApoE genotype, just like the Chinese cohort, that there was no substantial difference in ARIA instance between E4 carrier and non-carrier. Only E4 homozygote showed higher ARIA instance than the non-carrier. And this finding, as you all know, that very different from the Clarity AD result. And in the Clarity AD, the ARIA ApoE for carrier, the ARIA instance was 2 to 3-fold higher than non-carrier. And one possible explanation is the prescription pattern of Korean physicians. Many Korean physicians prefer the dose titration at the first infusion, not rather than the full dosage, 10 milligram per kg at the first infusion, maybe to reduce the risk of ARIA. And actually, 54.6% of patients receive approximately half dosage at first infusion and gradually escalate to full dosage by around 5th infusion. It's very interesting, the prescription pattern, but I think that is one of the reasons is that the lecanemab is not covered by the Korean the government insurance, so may which allow the Korean physicians to adjust the dosage flexibly with their own discretion, maybe, I think. And yes, and however, the further analyze ARIA instance between the dosings, the strategy, full dosage start and the titration dosage, but the instance is not too much difference between the two. Even the full dosage group, the ARIA instance is a little lower than the titration dosage. And finally, the ARIA severity, in terms of regarding ARIA severity, most cases were mild to moderate, and the symptomatic, in terms of the symptom, majority were asymptomatic, and especially 77.8% of ARIA-E cases were asymptomatic, and 94% of ARIA-H cases were asymptomatic. And so, in conclusion, the JOYARTS was the first real-world registry in Korea led by Korean Dementia Association, and the real-world patients are broadly similar in clinical trial population, but some with high risk of ARIA, the patients also received lecanemab despite general recommendation. And IRR was comparable to the Clarity AD trial, and the overall ARIA instance appears lower than Clarity AD, 9.5%, and the unique titration, the strategy is frequently used in Korean physicians for the patients who have higher risk of ARIA, and especially the ApoE4 carrier instance of the titration group is around 71%. So, which is higher than the full dosage from the start group. And we will continue to expand the JOYART registry and perform more comprehensive analysis as more data accumulate.
Data, I think a very high IRR, infusion reactions a little bit high, I think.
Actually, in the clinical Clarity AD clinical trial, the Asian subpopulation IRR instance was a little less than the general population. But in Korea, I don't know. The IRR the instance was very similar with Clarity AD clinical trial. And we observed the delayed IRR also, and actually at the first, usually most IRR occurred most commonly the first infusion, and then decreased sharply after the second infusion. But there are several. The instance is not too high.
So
but
during the infusion or after the infusion?
Usually,
is it immediate?
In my case, usually. After the infusion, after 2 or 3 days later,
I experienced those kind of.
So I prescribe some medication for patients, every patient.
Yeah, me too.
Okay.
So the infusion reactions between donanemab and lecanemab is different. So we experience more with donanemab. Anaphylaxis.
Dr. Iwatsubo.
Yeah. So I have a question about recruitment to your JOYARTS, and it's going quite well. And then, what is the current total number of registration?
Yes, 901 patients.
Wow.
Big data.
Till February the 24th this year. But we are the data that I told you were the data cutoff was last year, December 31st.
So do you have any specific efforts to maximize inclusion? Because doctors are very, very busy with the practice.
Good question. That is the problem also. So we really try to encourage the enrollment, and but as you know that the patients, the doctors and the nurses are very busy. So we send the news, web news every monthly, and competition. Call everybody once a month and
encourage the doctors.
The monthly web news, is this a sort of a research report or a sort of broad feedback that's provided back to the clinics and back to the patients? So it provides them some sort of give back and rationale for being part of this research registry.
Right.
Are you doing something similar with your work as well?
Yeah, we believe that we have to do that more intensively, but we are not.
Good afternoon, everyone. Thank you for the committee's invitation. Today I will present the talk is a clinical feasible framework to estimate the tau pathology in Alzheimer's disease spectrum. So for this topic is motivated by the clinical situation that currently we have the anti-amyloid therapy in Taiwan, and all these medication is self-paid by the patient. So the patient will ask us that is this medication effect, and how do the doctor choose the medication? What's your expectation? So we all know that the tau PET is the gold standard for staging for Alzheimer's disease. While the anti-amyloid therapy, we will see the patient with low tau burden actually drive the most clinical benefit. But here is the reality. In most clinical settings, especially across Asia, tau PET is often too expensive or simply unavailable. Our study will ask the simple questions that can we use the currently we already have, such as amyloid burden and cognitive score MMSE and standardized MIs barometric to accurately estimate or guess a patient's tau stage. So we developed a clinical framework to do exactly what aligns with the 2024 AA criteria. So first of all, this is the cross-sectional study. We look at a cohort 229 ACL participants across the entire AD spectrum. We quantify their amyloid burden, use the centiloid level, and use the data-driven approach to set the tau threshold in concurrent tau PET. We use the second generation tau PET. So we have the amyloid PET and the concurrent tau PET for each patient. We also build up the multivariable model using the routine clinical markers such as the amyloid centiloid level, age, MMS score, and the medial temporal volume. So the result is quite robust. The clinical feasible model discriminated high global tau burden with the AUC about 0.8 and the neocortical tau involvement with the AUC about the 0.8. In short, we did not always need to expensive tau tracer to see the tau pathology. The signs are already hidden in the routine clinical data. So our most practical finding for the clinician is what I call rule of 60. If we look at the patient with the amyloid burden between 21 to 60, above the 21 is because our amyloid PET positive threshold is 20. So if the patient has the amyloid centiloid score between the 21 and 60, nearly 94% of them has become to the low to intermediate tau, which is coming to a good response or the better response participant according to the donanemab. In this group, the MRI's medial temporal volume was the best way to spot out the outlier. However, once the patients come across the 60 centiloid marker, the probability of the high tau and the neocortical tau spreading jump significantly. At that stage, age and the cognitive score become your most powerful predictor. Specifically, every 1 point drop in MMSE, the odds ratio have the higher tau burden increase 20%. So if the person across the 100 centiloid level, about 80% of probability is belong to intermediate or high tau level. So here is our algorithm to talking about the clinical feasibility. We also use this cohort to study the biological stage and the clinical stage disconcordance. So from our cohort, about 53% is we call a clinical predominance group, means that the clinical severity is higher than the biological severity. Only about 30 to 40% is the clinical biological concordance group. Less than 10% is biological predominant group. It's the resistance group. So it means that in our group, almost 50% have the clinical predominance group. Means that this patient has clinical more severity than biological stage. It means that during this group, within this group, more core pathology within this group. Which kind of core pathology? Because from our clinical trial, clinical study, we only can estimate the cardiovascular burden. And indeed, in this patients, they have a higher cardiovascular risk compared with the concordance group. So I want to wrap up my study. Our framework provides a scalable, accurate surrogate for tau PET. It allows us to estimate the patient's biological stage, identify those who might be declined due to core pathology rather than just tau. So it's the clinical step forward precision medicine in the resource-limited setting. Finally, I hope that this clinical algorithm will help the clinician to do the one way. Based on this clinical algorithm, we have to do the internal variability. Internal variability is quite good, but we didn't do the external variability. We hope to do that we use the ADNI data. And this algorithm, I hope, first to help the patient, help the clinician how to choose the patient, and second one is that is this probability or this algorithm can help to predict the outcome of the patient. So maybe in the future we have a cover with another countries and use this probability to do a better selection, which person will be more priority to receive the anti-amyloid therapy. And thank
Very
you.
innovative. And the algorithm is open for public use.
Oh yes, that is. We submit the paper for a journal, and I think in the future it can for public use.
Do you adjust the educational level for the participants?
Yeah. We adjust many confounding factors. For example, we adjust the age, sex, and ApoE genotype. We know that the sex will be have some confounding for the development of the tau and schedule. But in our cohort right now, maybe our sample size is not large, but at least from our study, I found that gender and the ApoE genotype did not affect the cutoff threshold.
So by using this algorithm, maybe you will disappoint many patients.
Actually, I like to say that if the centiloid above the 100, it not exclude the patient. It just tell the clinician that, or tell the patient that you also have the higher tau burden. But it doesn't mean you have the poor prognosis.
Okay, very good. Yeah. Any other question raised from our audience?
Are there brain bank in Taiwan?
We just started from the Taiwan Brain Bank, but in about 1 year or longer. But currently, I think we don't have the dementia brain bank in Taiwan.
Because I want to know about the biological, the severity, severe group, and the clinical, the
pathology correlation.
Discorrelation.
Yeah.
If we can see the pathology, we could know. Understand the core pathology, maybe the TDP-43 something.
Yeah, that is very good suggestion for our government. I have a question about the first one is that because Taiwan have the same situation regarding to the both anti-amyloid therapy in Taiwan as in Japan. So we always face the problem that the patient or the caregiver ask which one I need to choose. So the first question is that in your situation, how to explain that which monoclonal antibody for particular patient, or how to explain patient need to do which way of do the shared decision making. And this is the first question, and later I have another question.
So patients choose which to treat with lecanemab or donanemab. They choose. So of course maybe they want to come bi-weekly or once a month. I don't know. Maybe they want to do amyloid PET at 12 months, or Yeah, it depends. They actually want to know which is effective.
Okay. So the people in Japan like to choose which one is more effective to remove the amyloid rather than bi-week or monthly.
So they are not so interested in the bi-weekly or
okay. Okay, in Taiwan we have the same situation. And another question is that because when we explain the lecanemab for our patient, based on the clinical trial, we need to finish the 18 months treatment. During this month, we still continue. And so some of the patients ask me that when the patient receives the lecanemab and the amyloid burden is clean, should he still be continue till the 18 months or not?
So do you measure amyloid clearance?
I mean amyloid pace. No, what? Amyloid PET during, for example, 6 months or the 12 months, according to patient wish. Lecanemab. Yeah. So when patient reach the amyloid clean during the, for example, 12 months, should he still be continue till the 18 months or not?
So what do you say?
I just explained for the clinical trial. So based on the clinical trial, I need to still continue. Yeah. But I don't know. Yes.
The clinical trial recommends the full 12 or 18 months based on the data, but if you've got clearance and the patient has responded, is there more of a desire to take the patient off of the drug, but not only for a patient safety consideration, but possibly for throughput for more patients to come through?
Yeah.
For your patient, did you, for your patient who receiving the lecanemab treatment, do you prescribe older amyloid PET during the treatment? Any of the lecanemab receiver?
No, we don't perform amyloid PET for lecanemab patients.
So no answer in Japan.
Yeah.
So it's not covered by insurance. So I don't know if it's cleared or.
But Japan didn't cover the PET.
Yeah, but some patients want to know their amyloid status, so they pay their own money.
Yeah.
Some people.
It's the same situation in Korea. The lecanemab is the only DMT drug in Korea. Because the donanemab has not been approved yet, and the government don't cover the lecanemab cost and MRI and amyloid PET also. So
when you start the therapy, do you
test amyloid? Actually, in Korea, the amyloid PET cost is relatively cheaper than other countries, around $800. So nowadays, many clinicians check the amyloid PET when they are routine clinical practice. So many Korean patients nowadays they know about these kinds of DMT drug. The awareness is increasing. So some patients and their families came to me to ask about the DMT drug and ask to check the amyloid PET. So it is very common to check the amyloid PET in Korea. However, the situation is a little bit similar in Japan and Korea. Is the hospital facility is limited because there are lack of the injection room because so many the hospitals wants to cover the oncology patients. So there are competition. So it is too difficult to inject the dementia patients sufficiently. So it's the same situation in Korea.
Dementia research getting the short sell against oncology or more profitable
as well. Another thing is the amyloid PET follow-up is usually in Korea. The governments don't cover the amyloid PET cost, but some patients want, and we recommend 6 months or 12 months or even at least 18 months. That is we explain them we need. And usually the patients want to check after 6 months or 1 year. And as for me, actually, in my case, I treated only 40 the lecanemab patients, but I followed up the amyloid PET 11 patients, and 4 patients out of 11 patients changed their amyloid status to the negative, which means that less than 24 centiloid. So at that time I explained, I asked to the patients and their families to want to use the lecanemab continuously or stop. And I was really surprised because I expected that they wanted to stop because the cost is very expensive. But all 4 patients and their caregiver want to continue to take the drug. So it is because I think they are very desperate and fear about price is very expensive.
These are interesting regional nuances and challenges with cost, access, approval, where the current science is going, and how we're all trying to follow the clinical trials, which were designed without really any of this in mind in particular. Do any of our other speakers have any follow-up thoughts here?
So I was wondering how much time do you spend to explain about the donanemab and lecanemab to your patients and their families?
Not so long. Maybe.
Oh, really?
Maybe 15 minutes.
Actually, in Korea, even for me, I usually spend at least 30 minutes. So it's too burden for the clinicians. So actually, I want to know about some consultation fee or education fee.
I not only see dementia patients but other neurological disease. So we are just normal. It's very fast. So I see lots of patients. So maybe other immunological disease and other stroke, maybe epilepsy, maybe kind of.
Maybe you could share some insights about how to get that knowledge to the patients in that 15-minute time frame to help save some of our other clinicians some of their time.
I use this chart comparing donanemab with lecanemab.
Some materials.
Some materials. They watch videos. They think about it for next application.
Okay. I have a question. The most interesting part of your talk was the ApoE status was not related to the ARIA instance. What's your opinion on that? Why was the reason?
I don't know. Also we found that the ARIA frequency is also very low in our population. And currently we almost completed a more large real-world study. We recruit more than 1,000 patients with amyloid antibody treatment, and we publish the we want to know whether some bears However, from our study, you will find that the frequencies of FEP for coverage is high, hence is perhaps large enough to answer this question.
So, would you let me know the average the MMSE score in your patients? And I really wonder the average MMSE score.
Most of the subject, the patients in our study, their MSE score is higher than 20. However, we also include some severe, moderate AD dementia patients. In China, some patients, although they are not the early Alzheimer's disease, and perhaps their MSE score lower than 20. However, 20. However, they are their family and the patient, they want to use it. And we found that it's another time so that the lecanemab treatment, is also safe for this moderate dementia patient. And we are not sure whether the patient will benefit from this treatment. However, from our data, we found that for this moderate AD patients, there is very high discontinued, this treatment because perhaps some months later you found that their cognitive still decline. They don't want to use it anymore.
So is it covered by the insurance?
No, in China, and from our study, all the patients pay by themselves. And their family.
So I also have a question about the relationship between ApoE genotype and incidence of ARIA. And you mentioned that the overall ARIA incidence rate is very low in your cohort, and it has been also been an experience that with us in Japan and Taiwan and all over in Asia. So what do you think of the cause of the relatively low prevalence of ARIA with us in Asia?
Perhaps in my opinion, perhaps it is a genetics, genetics background, genetic background. The most difference between Asian populations and Caucasian population, perhaps the genetic background.
So there may be some additional genetic factors other than, in addition to the lower ApoE epsilon-4 prevalence with us in Asia. Do you think that there is something additional?
And however, from our study, you will find that for the patients receive the treatment, the ApoE4 carrier is still very high.
56%.
In the current AD clinical trial, the ApoE for the proportion is maybe the 68 or something. So high. So your cohort is the ApoE, for instance, is relatively lower than. Actually, in Joyard's registry, the ApoE for carrier instance was, I will tell you later, but around 62 or something. So which is also less than the current AD clinical trial. As Professor Iwatsubo said, that the Asian populations, the ApoE for the carrier instance is relatively lower than Western society. That's true.
Especially for the 2 copy of ApoE4.
But I suspect that there may be some additional factor in addition to the lower epsilon-4.
It sounds like a good future research study for you all to collaborate on. So is that additional genetic background that we play the role? Dr. Shi, did you also have a question?
Yeah, so not regarding to the ApoE for the adverse event, you also mentioned that you observed that the amyloid pathology decrease, while the tau level unexpectedly increased in specific cortical region within 6 months. And it's fantastic. So do you have any explanation that although the amyloid decrease, but the tau burden still increased within the 6 months treatment?
From this study, we found that in our center, about 200 have the follow-up topic, and we found from the short-term study, we found that the tau burden is stable, and we just analyzed with, as I just said, larger real-world studies that more than 1,000 subjects. We found that very interesting. From our primary analysis, we found that tau burden still decline. Okay. Also decline after treatment in you need more than 1 year follow-up.
Okay, the tau burden will be
it's going to increase, but then it's going to come down.
And then decrease.
Decrease.
So it's a delayed slowing of metalloaccumulation that may eventually start to reverse as well.
From this study, the p-tau217, JPEG significantly decreased, although only short-term follow-up. However, AFL neurofilament not change, didn't change.
So regarding to the ApoE questions, so in your study, ApoE genotype did not affect the adverse effect. So do you think that in ACL population, microhemorrhage burden should be weighting higher compared with the ApoE genotype?
And in some countries, the amyloid antibody was not approved for ApoE for carriers. And in my before this study, I also don't recommend patient with 2 copies of ApoE. However, after this study,
This is changing the practice.
Okay, Dr. Iwatsubo, thank you. Your presentation further support the value of plasma biomarker to predict cerebral amyloidosis. I am very interested in the subpopulation in your study. That is preclinical AD. When they realized that actually their friend has some amyloidosis, but not meet the treatment guideline. So what their response and what's your attitude to teach them to do something?
Thank you very much. In Japan, the prescription of anti-amyloid drug is strictly regulated by the optimal use guideline, and then we strictly limit the use to the symptomatic patients from MCI stage to mild Alzheimer dementia stage. So in the preclinical Alzheimer's, those have clearly the CDR global score 0. So as we all know, the clinical trial for those population is now ongoing as an AHEAD study for lecanemab and Trailblazer 3 study for donanemab. So if the patients are cognitively unimpaired, we say that you are in a maybe in a very early stage of the Alzheimer's pathophysiology. So you are not the target for the standard therapy right now.
So you want them to wait and see.
Until then, we have some positive results by the preclinical clinical trial, and we have to do that.
Okay. And the same in Korea?
Yes, we are same in Korea. And some patients came to me to get 2 months to use the lecanemab, even though their cognitive function is completely normal and all the laboratory tests is completely normal. But some doctors use and some doctors no. As for me, I persuade them to not to use the lecanemab because we don't have any evidence, right? But if Dr. Iwatsubo, just like Dr. Iwatsubo said, that if we will get the evidence, if we really see the evidence in the clinical trial, just like the Trailblazer 3 or the Lantern attack, the clinical trial, we could use in some future. I hope.
My question is that Professor Iwatsubo, your cohort is quite good and so large. So also provides a basic concept for plasma biomarker application in the clinical situation. But because as we know that in ACL population, the ApoE genotype is different from the Western country. So the question is coming from that we currently use the p-tau217, use the Western countries cutoff. But do you think that we need to have the ACL cutoff based on the different genetic variation?
Your questions were on the current program. So I have had that from pharma people that the p-tau 217 elevation is quite lower in the Japanese volunteer populations. I'm talking about the preclinical asymptomatic stage. So there may be some problem of deviation in the selection route, of course. Yeah, that we also know that in the clinical trial, the average amyloid central level was lower, especially in the donanemab clinical trial. So that the amyloid burden is lower with the Japanese, and then probably in overall Asian population. So, what about the setting of cutoff line? So we may have to think seriously or carefully. But in a global clinical trial setting, we may need a relatively uniform cutting point. So that is still very important and a question.
I have a question. Your topic is very the hot topic in these. I was wondering that do you think can we use the plasma p-tau 217 is a kind of the progressive marker?
An efficacy.
Efficacy.
And I mean do you think that the p-tau 217 is well correlated with amyloid PET amyloid level?
So we haven't compared the correlation very carefully, but the previous clinical trial data, and then of course our data shows some very good correlation between the level of 217 and amyloid centiloid levels. But as I mentioned, we hope that the 217 reduction rate or may be correlated with clinical efficacy, but probably some analysis have already been done with the clinical trial data, and it looks like there's not such a very good correlation and prediction by the changes of the p-tau 217 level.
How about the MTBR tau 243? Because I was wondering that what kind of the plasma biomarker is well correlated with clinical symptoms?
So I am not aware of the latest data, but I remember. ASI people have shown some very preliminary data on the quantitation of the change of EMTBR in the treated patients, and they showed a larger decrease compared to the changes in the placebo level. So there may be a chance that EMTBR that is more directly correlated with the tau burden that is related to the neuronal loss and cognitive changes as a measure, but probably they haven't completed the full quantitation by MTBR.
Dr. Park.
The result and the presentation is very, of great help for us. And do you have a AUR at the national level or society level?
The society level.
And I noticed that perhaps some proportion of patients out of level use.
Right.
So it is a...
That is real world.
It's the real world.
Actually, some patients came to me, as for me, one case, I remember one case that he was EOAD patient, and his MMSE score was 12, but his wife strongly want to use the lecanemab. So I persuade, I explained for 1 hour about the side effects and the benefits from the lecanemab and compared with each other. But finally, she moved another hospital to get the lecanemab. Yeah. So this is the real world situation. The patients and their families are very desperate. So they want to do something, anything, even though the benefit is reduced from our evidence, but between our compared to our the evidence.
So we can understand. But is there anyone preclinical AD?
Not for me, but the preclinical AD, there are very small portion, but we have the preclinical, the subjective cognitive decline patients also included in our registry.
Okay, thank you.
I have a question regarding to your graduate titration infusion protocol. That is because that in our country we usually starting from the full dose and in the first time. So the lower IR infusion related reaction maybe related to graduate titration that's protocol. My question is that because the graduate titration is the protocol, did they affect the, for example, the efficacy for the amyloid clearance, or delay the longer use, or the response?
We saw the amyloid the clearance rate between the titration group and the full dosage group, and there was no significant difference between each group. And of those group, we followed up 6 months the amyloid PET image around 56 patients, and the average amyloid the deposition level was decreased around 30 centiloid, which was very similar to titration group and non-titration group.
Okay.
And as for the efficacy, in terms of efficacy, and we followed up MMSE and CDR after 6 months, and those two groups also decreased the MMSE statistically significant decrease, cognitive decline after the 6 months. The efficacy was not different within each other.
So what's the baseline amyloid burden?
Around the 75 or
75.
The mean amyloid central level was 75.3, which was very comparable with Clarity AD, 77.9.
Actually, I was curious because you're talking about a real-world population. You're talking about individuals, with a lot of co-pathologies with Fizeka scores of 3, for example. But it sounds like you're telling us that these therapeutics are still being as efficacious in removing the amyloid and in not producing side effects of concerns, even in these more real-world cohorts that were not included in the clinical trials.
Right. But so the proportion is very small, so we couldn't see the statistical the differences between the groups. But this is very I think very valuable things for this kind of real world the registry. And if we we are gathering the data, and if we do more comprehensive analysis with larger data set, maybe we could answer your question.
Yes.
So do you have a plan to correlate for example, some plasma biomarker or even the tau PET images in a subset of your?
So thank you. So from this cohort, we just only have the clinical measurement and the image measurement, and then in the future we maybe have like to collect the plasma biomarker to correlate with this cohort.
Could I possibly follow on to that? As an imager and somebody who always wants to see more use of imaging in these trials and in these cohort studies, Your abstract talked about this being the second generation tau PET tracer, APN 1607, which is still being evaluated for its use not only in AD tauopathies, but non-AD tauopathies as well. So my first question is a little bit for you in terms of what do you think is sort of the sensitivity of APN 1607, particularly in Alzheimer's disease. But after that, actually, could we kind of go down the row and ask what are the tracers that are available to you or that you commonly use for both amyloid and tau PET for each of you?
Yeah, the first question is that the APN 1607, this second generation tau tracer, that is sensitive to catch the tau burden in variety of neurodegenerative disease. As my experience is that first of all, for the Alzheimer's disease, I think yes. My answer is yes. The clinical the clinical experience like this one. Some of our patient clinical participants receive the amyloid PET scan and the tau PET scan. So, because there is some time interval between the amyloid scan and tau PET scan, we do the concurrent scan within 1 month. But first, the patient do the amyloid scan. And the amyloid scan level, central level is within the borderline. So the nuclear doctor judge as the equivocal or negative. But if they see the tau PET scan and the tau PET scan is positive, he will change the amyloid scan. So that will be interesting. So for me, for Alzheimer's disease, I think at least we have some experience regarding for this, and we know that amyloid PET scan is blurring, and sometimes it's very difficult for this kind of the patient to judge is positive or negative. Although we have some centiloid tool to judge, but there is a job is a borderline. The second one is that a different degenerative disease. For me, I have do very some such for example, progressive supranuclear and corticobasal degeneration. Both of these participants show the positive scan in the different neuropathological disease. So for the sensitivity, I think this second generation tau PET tracer is quite good, and also there's benefit for the very few of target binding, because we also have the chance to use the first generation tau PET tracer, THK tracer. So in that patient, we are difficult to see the movement disorders disease, but because they have of target binding in a basal ganglia region. Your second question is that
well, I was for the whole panel, including yourself. What are the tracers available to you, and what are sort of in common use in your region?
Yeah. Actually, this tau PET tracer in our hospital is for clinical use. In Taiwan, we also didn't have the tau PET tracer available for the clinical practice. Even we have the AV11451, but it's just only for the study. Yeah.
I'd be curious about any of the rest of you about the tracers that you're commonly using.
Yeah, so in Japan, there are 3 amyloid tracers are available, and then pro-beta-PL amyloid, and then flutamidamol, Bizamyl, or very widely used by the delivery from the factory. And then pro-betamine is very limited, but the synthesizer is available. And then those amyloid tracers are reimbursed if they are used for the diagnosis, not the diagnosis, for the decision to use anti-amyloid drugs. And in terms of the tau PET, only one tracer, flow tau CPL, tau bit, that has been approved, but that is not reimbursed. So that is related to the approval process of lecanemab only. But in our ongoing registry study that we are going to start the sub-study that covering the participants that are by protospian and to see whether the tau negative or slightly positive population that showed very similar efficacy, clinical outcome to the low to moderate or high population. Because all the amyloid positive asymptomatic patients that have been approved to use donanemab. Yeah, so we are doing that with donanemab, but we have to ensure that the tau negative patients also has show some efficacy. Yeah.
I would love to hear more.
In Korea, we also the three of the amyloid PET tracers are available: the fructometanol, flurobetabine, and Betafir. And Betafir only used the clinical research purposes, and another two the tracers are being used as in real clinical practice. And one other tracer are being used in Korea, which is very, but not so many clinicians who use that tracer. And in terms of the tau PET, any tau PET, we don't have any approved tau tracer in Korea, which is very the big problem. So the only way we know the tau, the burden of the patients is the CSF study, and the ROSHU, the Alexis, the technique was approved last year. So now we can, if we want to know the tau pathology, we have to use the CSF study only. Yeah.
Dr. Kujuro, would you like to share on that question as well as ask any other questions?
Currently in Japan, we can't perform tau PET, so. But to better understand the pathology of Alzheimer's disease, we need to know the status of tau. So I hope the biomarkers, blood-based biomarkers, that will be available in the future.
Which tracers are you commonly using in your work?
Amyloid.
Which amyloid tracers, for example? So do you use the same tracer?
Yeah, in my hospital, I use the flurobetamol and Dizamil and the Miracek, the flurobetabine. Two tracers are used in real clinical practice. It depends on but I also use the Dizamil much frequently used because we can see the Dizamil is the color reading, so I can show the amyloid status to the patients. It's very intuitive.
It seems like a small thing, but it does really, I think, help with the interpretation, not just to the patients, but possibly even to the readers as well.
I think that this for the prediction of the patient's outcome, just I say that above the 100 centiloid, 80% will become to the intermediate high tau. Or for my treatable patient, I have the 20% use the donanemab. Within this 20%, we have the 5 cases to finish the 6 months treatment, and 3 of them has come to the donanemab, and 2 of the cases is above the 100, and they after the 6 months treatment, the amyloid level still amyloid PET still positive, but it will reduce about these 2 cases. Average is reduced to 6 centiloid. So although did not come into the negative stage, but I can expect that maybe in the 1 month or 1 year, this patient will come to the clinical amyloid negative state. So that's what I thinking. This algorithm can let clinician tell the correct expectation for the patient themselves. Yeah.
I want to add our experience for the lecanemab, and actually we also analyzed the amyloid clearance, the burden, amyloid burden after the 6 months, and then the negative conversion, the patients, the average baseline amyloid centiloid was around 40.
40.
Yeah. But
6 months.
Yes, after 6 months, still the positive patients, the average the centiloid level was around 80.
Okay.
Yeah.
Yes.
So, which means that the donanemab may have a strong, stronger to reduce the amyloid burden. Because that the donanemab is the target is the amyloid plaque.
The kind of related back to some of the ARIA findings of the side effects as well.
Side effects, right.
Yeah. So I have sometimes I have a fantastic or crazy thinking is that because our purpose is first one is clean out amyloid burden, and so we can choose one of the stronger medication, but we know that Alzheimer's disease is a continuing disease. Although you clean out of the burden, it will gradually progress. At least some of the prototype will come out. So during this period, maybe we can use the maintenance therapy for protect the patient. That is the fantastic thinking. Yes.
Thank you very much, everyone. This was a fascinating series of presentations and an engaging discussion. It was very interesting to me to hear about, again, not only your individual research projects, the registries that are being created, the potential future collaborative research opportunities that I hope you will all engage in together, but how we're learning much more information that can go back into not only real-world clinical practice, but also can inform upon how trials might need to be run differently, or future trials might need to be run to test things like maintenance doses, titration effects to control side effects, pre-medications to try to minimize some of these injection site or other types of reactions as well. So thank you very much for your time.